All right. Hi, everyone. I am happy to be here today on behalf of our team to present some of our work on cognitive impairment in older adults with HIV infection. Next slide. There we go. All right, here's an outline for today's talk. I'll share some background on Kaiser Permanente healthcare and research, review some findings from our preliminary studies of cognitive impairment and dementia in people with HIV infection, and
Could you please move closer to the mic?
oh, okay, sure. Here's an outline for today's talk. I'll share some background about Kaiser Permanente healthcare and research, review some findings from our preliminary studies of cognitive impairment and dementia in people with HIV infection, and discuss future directions for this work. First, here's some context on where this research is being conducted. Kaiser Permanente is an integrated healthcare delivery system and not-for-profit health plan in the US. What this means for the individual patient is that they can get all their health services within the same health system and through a single health plan. And this includes primary care, specialty care, prescriptions, and laboratory services. Patient care is facilitated by electronic health records, which comprehensively document a patient's medical history, diagnoses, and healthcare utilization. Kaiser Permanente health systems serve multiple regions nationwide with a national membership of about 12.4 million. Its largest membership is in California, and this is where I'm based in Northern California. Within each of these health systems is a research center with projects on a broad range of topics related to health and healthcare. Most of the research are epidemiologic studies using data from the electronic health records. About 30% are clinical trials. There's a strong focus on implementation and translation of research findings into the clinical setting. So studies are conducted in multidisciplinary teams, typically involving researchers like myself, who have a background in epidemiology and public health, and it's done in partnership with practicing clinicians. Research on cognitive health, specifically in people with HIV within our health system, is fairly new. It was prompted in 2019 by clinicians reporting a high burden of cognitive complaints among patients with HIV. There were also some anecdotal reports of patients being diagnosed with dementia at earlier than expected ages, despite being on HIV treatment. Another concern that was raised included uncertainty on how to address cognitive health among patients with well-managed HIV. Similar concerns were voiced by patients in our patient advisory group. This is a group of current patients receiving care at Kaiser Permanente. They review our research portfolio on HIV and aging. They provide input on topics of interest and feedback on how these topics should be prioritized in our studies. Things that patients were concerned about included forgetfulness and wanting to better understand what's due to HIV versus aging, and not specific to cognition, and something we can probably all relate to is how can we age with confidence and knowledge about our health? So to back up a bit and give a little bit more context on these concerns about HIV and cognitive impairment, here's what we know about HIV in the brain. HIV is known to have neurologic effects. HIV enters the brain in early stages of infection. Uncontrolled HIV can cause a spectrum of neurologic complications, including HIV-associated dementia, which is a specific form of dementia that's rapidly progressive and due to the direct effects of HIV on the brain. These neurologic complications of HIV are rare in the context of antiretroviral use. However, HIV can remain latent in the CNS despite viral suppression. There's also extensive work from research cohorts showing that despite antiretroviral therapy, cognitive impairments remain common in people with HIV. They're mostly mild, but they're estimated to affect about 30 to 50% of people with HIV. Better understanding this relationship between HIV and cognitive impairments is especially important now, especially since most people with HIV infection in the US are over age 50. This is the fastest growing subset of the HIV population, and similar trends have been observed in other countries. Also, as people with HIV are getting older, many are reaching ages when they're experiencing some age-related changes in cognition. And I want to pause here on this graphic to show how I visualize the relationship between cognition and aging. So we are all getting older, right? And as we get older, we are all likely to experience some level of cognitive decline. That's normal. That's depicted by the black line at the top of this chart labeled normal aging. Mild cognitive impairment, which is abbreviated MCI in the orange text here, is a clinical diagnosis for when a patient's cognitive decline is greater than what would be expected from aging alone. And it's typically thought to be a precursor to dementia, which is diagnosed when cognitive impairment is severe enough to interfere with everyday life. Now, looking at this graphic from an HIV perspective, one of our greatest challenges is that the relationship of HIV, cognition, and aging is complex and it's poorly understood. So now let's dive into some of our research on HIV and cognition in our health setting. In our initial studies, we focused on answering 3 questions. First, are people with HIV at greater risk for age-associated dementia? Second, what is the epidemiology of age-associated dementia in people with HIV? And lastly, what's the extent of undiagnosed cognitive impairment among people with HIV in primary care, especially since routine cognitive screening isn't typically done? Since we hadn't studied this before, we started by doing chart reviews because we wanted to make sure that we could accurately capture dementia diagnoses using data in the electronic health records. This process allowed us to identify a set of ICD codes with a high positive predictive value for identification of dementia in people with and without HIV. It was 93% in people with HIV, 97% in people without HIV. And these predictive values were not significantly different from each other, which is good. That meant that our case capture was comparable for people with and without HIV. So once we had a case definition, we took a look at dementia diagnoses by HIV status. And here's what we found. Looking forward in time from age 50, the cumulative proportion of people diagnosed with dementia by age 80 was 26% in people with HIV, and that's shown here in the red line. And that's compared to 14% in people without HIV. Importantly, I want to point out that everyone with HIV included in this study was on treatment, and they're being compared to demographically matched people without HIV. So, what does this look like after accounting for dementia risk factors, right? People with HIV are more likely to smoke, they're more likely to develop cardiovascular disease at younger ages, and these things could increase dementia risk. So next, we did a series of nested analyses where we adjusted for these factors. So first, we adjusted for sociodemographics. Then we added in adjustment for smoking and substance use, cardiovascular disease, diabetes, obesity, depression. And as you can see from the hazard ratios here, these factors appear to account, in part, for some of the elevated dementia risk observed in people with HIV. However, even in the final model, on the bottom row here, which additionally adjusted for frequency of healthcare utilization, people with HIV remained at 58% higher risk of developing dementia compared to their age-matched peers. So that study I just presented was done at Kaiser Permanente, Northern California only. Our next step was to partner with Kaiser Permanente in Southern California and the Mid-Atlantic states, and we pooled our HIV data. And this increased our sample size, but importantly, it increased the diversity of our study population. In Southern California, a greater proportion of people with HIV are Hispanic, and in the Mid-Atlantic states, including here in Washington, D.C., most people with HIV are Black. In California, only about 10% of people with HIV are women. Here in the Mid-Atlantic states, 30% are women. Then we took a look at dementia again, and this time we looked at trends over time from 2000 to 2016. What I want to highlight here is that dementia incidence in people with HIV declined substantially, and that's shown in the red line here. However, even in the most recent time period, dementia incidence in people with HIV remains significantly higher than that in people without HIV, even after adjustment for dementia risk factors. Here I show prevalence. So just as in the previous chart where I showed incidence, dementia prevalence was higher among people with HIV in all time periods of our study. And again, even in the most recent time period, and even after adjustment for confounding factors. This work led to a publication in AIDS and an editorial commentary on the persistent disparity in brain health among aging people with HIV, despite access to care and despite HIV treatment. So overall, in our initial studies, people with HIV were being diagnosed with dementia about 10 years earlier than their HIV uninfected counterparts. But those studies were just retrospective, electronic health records-based studies. So we were curious, what might we be missing, and could there be undiagnosed cognitive impairment in people with HIV? So we did a small prospective study which involved cognitive screening, and we enrolled folks using the same criteria that we used for our EHR-based studies. So people with HIV on antiretrovirals, age 50 and up, with no prior dementia. And people were placed in 3 categories based on their cognitive screening results. 58% screened cognitively normal, 36% as cognitively impaired, and 6% as having possible dementia. Here I want to point out that these categories are placed in quotes because they're not clinical diagnoses. They're identified by the cutoffs of the cognitive screen to identify folks who may benefit from further cognitive evaluation. The take home for me here, though, is that this puts a broader lens on our EHR-based studies because it tells us that there may be undiagnosed cognitive impairment that's not captured when we look at EHR data alone. Then, among people with cognitive impairment, we asked whether they were having any difficulties with everyday activities. So things like housekeeping, performing tasks at work. 30% of people with cognitive impairment reported difficulty with at least one everyday task. 67% attributed these difficulties to cognitive problems. What I want to point out here is that that's not necessarily unique to HIV. However, when that occurs at earlier than expected ages, right, among people who may be still of working age, for example, it could have substantial impacts on employment and quality of life. So thinking about these initial studies that we've done and where that leaves us, I have a few key takeaways. Circling back to our initial question of whether people with HIV are at greater risk for age-associated dementias, we found that according to our initial study, yes, they were, even after adjusting for dementia risk factors, even among people taking antiretrovirals. Why is this? In next steps, I think it'd be important to tease out what are the relative contributions of HIV and non-HIV factors to risk of dementia. What are the modifiable factors and how can we intervene? Regarding epidemiology, we found that in people with HIV, dementia incidence declined over time, which is encouraging. That may reflect improvement in antiretrovirals. However, incidence and prevalence of dementia remain consistently higher in people with HIV in all time periods of our study. This deserves a closer look. Where are there disparities? Where are there interacting demographic and structural inequities that may be contributing to dementia risk? And finally, in our small exploratory study, which involved cognitive screening, we found that dementia may be underdiagnosed in HIV primary care. And therefore, we may need better methods to identify cognitive impairments earlier. In terms of patient care and making the best use of limited time and resources, can we risk stratify so that we're identifying the people who are at greatest risk of developing dementia and who are most likely to benefit from a cognitive evaluation? Also, more work needs to be done to better understand the link between cognitive impairment and functional impairment and how these findings can be meaningfully translated into the clinical setting. I think there's potential of EHR data in our health setting and in others to advance our understanding of cognitive impairment and dementia in people with HIV and to answer these questions. There are limitations too, and I look forward to learning more about everyone's work today and to think more on how EHR data can best contribute to the very broad, very rich research discourse in this area. In conclusion, a motivating factor for me in this work is wanting to better understand how people with HIV can live well as they age, with minimal cognitive and other aging-related conditions that could potentially reduce enjoyment of life. To that
we'll
end,
have to wrap up. Really.
Okay. I'm grateful for our patients, healthcare providers, and researchers who've shaped research ideas and directions. This work would not have been possible without our collaborators, including our Mid-Atlantic team led by Michael Horberg, Southern California team led by Bill Towner.
Really, we have to wrap up.
Okay. Thank you very much.